Uterine fibroids are non-cancerous growths of the uterus. They become more common as women age and can be found in up to 70% of women. STARmed's Viva RF generator delivers radiofrequency energy through a dedicated mode for the treatment of fibroids. STARmed's Star Fixed, Star Bipolar, and Viva 2 RF electrodes have all been designed specifically for the treatment of fibroids. The Viva 2 RF electrode is an adjustable electrode. The active tip can be adjusted from 5 millimeters to 30 millimeters. To begin, first connect the Viva 2's RF power cable to the Viva RF generator. Then, connect the blue inflow tubing and make sure that the tube's arrows are facing the same direction as that of the pump's flow. Depending on the electrode, attach 2 or 4 grounding pads on the patient's thighs. Uterine fibroids are approached in different ways depending on their location and size. Compared to other approaches, the transvaginal approach provides patients the advantage of being able to recover quickly after the procedure and continue their normal activities the next day. To start the procedure, first attach the ultrasound probe to the guider. Adjust the length of the electrode's active tip according to the size of the fibroid. Then, insert the electrode into the guider. Target the fibroid by confirming its location under ultrasound. To perform the procedure using the moving shot technique, set the Viva RF generator to the continuance mode and adjust the RF power output. The moving shot technique can be performed by pulling back the electrode and ablating unit by unit. This technique helps limit the thermal damage to the surrounding tissue. Continual observation of the ultrasound image and generator impedance will be helpful to achieve a complete and safe ablation. After the procedure, most patients should experience a dramatic improvement in their symptoms and a decrease in the size of their fibroid. The benefits of uterine fibroid RFA include a minimally invasive procedure usually performed in an outpatient setting with local anesthesia, a short procedure time, a quick recovery allowing patients to continue their normal activities the next day, and low complication rates.
Hello, everyone. Good evening. I am Giovanni, the EMEA Director of STARmed. Thank you, and thanks a lot for joining the STARmed webinar about the current role of RFA in management of the uterine fibroids. We will have Q&A session at the end of our webinar, so do not hesitate to write your question anytime in a Q&A session. But if you are exceeding with the time during that session, we will reply to you by email as soon as we can. So now I am glad and honored to introduce Dr. Karin Louise Anderson. She is PhD in Karolinska Institute of Stockholm in gynecology, and she is currently working in Florence at Palagi Hospital and Santa Maria Nuova Hospital. She's an expert in minimally invasive procedures, and she is also the coordinator of the Uterine Fibroids unit in both hospitals. So I would like to thanks a lot, Karin, to provide us this chance, and we are looking forward to see your presentation. Thank you, Dr. Anderson.
Thank you very much, Giovanni. Thanks for the invitation and the opportunity to share my experience with you, connecting doctors and technicians in regards to this very interesting and stimulating field. I will now share my screen so you can follow what I'm saying, and I hope that you will participate with questions. I will be happy to answer them afterwards and discuss with you, even if online, if needed after the presentation. So let's see if I'm disabilitato. I think, Misha, I need to get able to share my screen. It says that someone has disabled me to do that. So I can also talk like this, but it would be nicer for you if you see some images. So I don't know if Misha can hear me. Misha is our support this afternoon. Try again. I will do that. Perfect. I think so. We made it. Okay. Here we go. Perfect. So I will just take off this. So yes, the agenda. This is a little bit what we're going to go through. Just a very quick background around regarding fibroids. I guess you all are very familiar with the fibroids and the pathology in general, but just a few words about it. And of course, then getting into the radiofrequency field, talking a little bit about the mechanisms of action, the performance, the results that we have today, the data available. We still need to have more data, of course, and we'll be happy to contribute to our ideas and the future perspectives and ongoing studies. So what we know, of course, about the fibroids, that it's a big burden. I will just say, I'm not actually seeing perfectly my slides. I'll see if I can get them a little bit less. Sorry about this.
I can see perfectly, Karin.
You can see, I cannot, but it's I know more or less what I'm supposed to talk about, so it's okay. It's okay. This is just like, yeah, why do we have to talk about alternative treatments for fibroids? Because we know that up to today, also in countries, in very well developed countries, unfortunately, we do know that this 80% of our hysterectomies today are unfortunately made upon the reason of fibroids. And the estimated cost of myomas in, for example, US is about $2 billion a year. And this is not considering the cost associated with the IVF. So it's a huge amount of economically burden, the pathology. And of course, we need to be always more aware about the fertility preservation needs in our patients. Of course, many of the fibroids do not have any symptoms. So of course, we are happy to leave them out of our aims. But when they are symptomatic, we do need to offer to our patients the best solutions that need to provide a safe treatment. It has to reduce the symptoms. It has, when needed, to preserve the fertility and also provide long-term quality of life effects. So the ideal treatment is what we are aiming for. It also has to have to be cost effective, of course. It all depends upon where the fibroids are located, as you know. So we all have our different strategies as for instance, on a fibroid unit, you have to address the patients sometimes to surgery, laparoscopic surgery, hysteroscopic surgery, sometimes embolization strategies, or even more extensive surgery. But what we're talking about today is actually the fibroids that we have been having difficulties to treat so far, as I consider this field, because the intramural fibroids are those that are most difficult to reach with other endoscopic strategies, and also the ones that are less responsive to the treatment, to our medical treatment. So the intramural fibroids are targets. What do the women say? Well, the women actually, they more and more always express the desire for treatments that do not involve invasive surgery and to preserve the uterus. So we are all fortunately talking the same language. The natural history is providing the growth of the fibroid in medium 35% in 12 months. It can also go backwards sometimes, but more or less the fibroids, they do grow slowly but surely in the women's life. And yes, the studies show that the less they are in dimension, the faster they grow. So what our treatment of choice today is, the radiofrequency can really provide a volume reduction strategy. So we can provide something that reduce the fibroid volume, arrest the fibroid growth, which is very, very important in certain situations of our patient's life and situations. And we will see how. So we are aiming to personalize our treatment offers, which is always also an important aspect also in the responsibility we have to our patients. The setting of these treatments is very simple. As you saw, the videos nicely made by STARmed provided material. We have the generator, which is providing data, various data during the procedure, which makes it easy to follow the temperature of the electrode, the impedance and the power that we actually generate, the heat transfer to the tissue, and the ablation time. We do always use, of course, an ultrasound instrumentation that we put the guide to the electrode and the electrode that we use during the procedure, as you saw also in the video. And if you want to, we can show maybe the video after if we have time. I think it was really illustrated for who has not been seeing, is new to the field. So the electrodes are around 35 centimeters long, 16, 17 gauge of size. And of course, we can also provide a biopsy instrument if requested. The intramural myomas, as I said, are mainly our target. It doesn't mean that we cannot also, if a fibroid is like a G4 or 5, we can also, of course, doing the procedure in one fibroid. We can also, of course, treat nextly fibroid that are in the same patient during the same procedure. There's no really limits in this. We will talk about it maybe also with your questions afterwards. Someone might ask us, how many fibroids can you treat? Well, it depends upon a little bit the length of the procedure and how the fibroids actually are responding to the treatment. Because sometimes it's very, very quick, and we can also do more fibroids during the same procedure. I will show you quickly here how it can look when we put into the electrode. So we have the ultrasound guided assistance. So when I'm performing the procedure, I'm doing it with my ultrasound probe, the transvaginal probe, inserting the electrode. And you see during the procedure how the echogenicity in the fibroid changes. It's easy to follow the needle It's not a complicated insertion at all. They are performance very highly. They are cutting very easily the tissue, so it's not difficult to follow. You will see it even better here. Move quickly. We have speeded up this video a bit, but you can see how this is the dimension of the fibroid. You can use on your ultrasound, the settings. You can also put the virtual track, which makes it easier to find. Here you go in with the electrode to the farther distance of the myoma, where you start to your procedure in letting the electricity, the radio frequency move. And when the impedance gets higher, you move slowly. You can move slowly. You can take out the electrode slowly, like you see here. And the slice of the fibroid is actually made at this point. Okay, then you move around. It's a sphere, so you move around. Depends upon which electrode you choose. Of course, we have a variable exposure, which is very nice. You can choose how much you want to expose the needle, independent of the fibroid size. So as you can see, it's quick insertions actually, and mean time for 4-5 centimeter fibroid is less than 10 minutes. So it's, and you can see this is the third insertion that we do in this fibroid. And the aim is to have about 70-80% of the fibroid treated by the ultrasound verification of the echogenesis. So you can, after the procedure is done, you can see this kind of image. So what's happening is that we generate the thermal, the heat in the myoma about 60 to 80 degrees, and we create a tissue and cell death due to coagulation. And the ischemic necrosis with atrophy by the formation of vascular thrombosis in the vessels supplying the myoma, which means that with time it will shrink. It also, which is a very nice, I think, not side effect, an additional effect. It is actually preventing the tissue growth by inactivation also of the hormonal receptors within the myoma. So we have more causes of our fibroid shrinkage with time. Of course, it's something that we see with time. So we call in our patients after 3 and 6 months, 12 months to be fully checked up. But after 3 months, you often see a very good response. And after 6 months, even better. I will show you data on this. What is actually, yes, if not now, when the complex situation of today is actually this, that the time and timing in our patient setting is that the women's desire of pregnancy is postponed to a decade when fibroid prevalence is reaching its peak. So this is not a happy coincidence, which means that we need to guide and help our women in this window when they might need a pregnancy, not too far away, but they do, and they cannot wait maybe for an surgery. We know that after laparoscopic surgery, we have to wait. It depends upon what kind of suturing we use and all that we have been hearing about a lot. So sometimes it's really an indication to have a fibroid that needs to go to IVF maybe the next coming months or within a year. And we don't have time or possibility to do surgery. So, for instance, these fibroids we have been treated with good effects after 3 months. These are both women that were going into IVF procedures. Again, patient selection is important to offer good personalized medicine. Let's look a little bit about what we have, the data we have so far. This is a very big meta-analysis by Linda Bradley, which considers 32 articles in many patients, in more than 1,000 patients treated with different techniques. Of course, today we talk about the transvaginal radiofrequency, but we do have in literature, of course, other approaches as laparoscopic and also hysteroscopic. We talk about transvaginal, and I guess who's connected with us today is familiar with the transvaginal ultrasound, and it's very, very easy to apply this technique, especially, of course, if you have been also using pickup procedures in IVF settings. It's very, very similar. Here we have, in this review, we have a 12 months follow-up with a fibroid volume decrease of 66%. Honestly, I have to say that we have been having in our setting here in Florence, we've been having very nice results, also much previous to a 12 months follow-up. Also in 3 to 6 months, we have been having a median of 80% decrease in volume, fibroid volume. What's important, of course, it's the quality of life scale, increasing by 39 points in women, and the severe scale decrease significantly, which is very important, of course. Let's talk about a little bit the reintervention rate. Of course, as you can imagine, this is not homogeneous data, so you have to look a little bit more closer to, I think, and we need to study this better, who is maybe going to need a new procedure. It depends upon what age, of course, the woman is performing her treatment. The woman that is performing her treatment at 47 years of age and then going to menopause, of course, she's not included in this group, while the woman that might be having an IVF at 35 years of age might be having a new treatment in her life. It also might be new fibroids, of course. It's not specified in these articles if there are the fibroids that are really treated, or it might be a new fibroid. That's also an important issue, of course. This is another important article talking about the efficacy complications and the predictive factors to response or treatment. And here we can see how the total days of menstrual bleeding are decreasing, and the days of menstrual bleeding, how they decrease in a significantly way, which is very good results, and also, of course, contributing to the quality of life aspect of the patients treated. The myoma volume as well, as you can see, the baseline is also significant decrease in the volume, and the influence of patient's age is also reported in this study. What we can see also, of course, in the percentage of reduction in volume is higher if regards to the baseline volume, and you can also see in the age that the women that have fibroids in the later age also might respond a little bit less. This may also depend upon how the fibroid actually is molecularly, because more very stiff and hard fibroid might respond less than a softer and more vascularized fibroid. These are data that we don't have, but we presume this is how it can work. Of course, the influence of the initial volume, as we said, the reduction in volume also is dependent upon how big the fibroid is from the beginning, of course. And also the volume and the procedure duration. You can see that the procedures are all very quick, actually. So I personally don't see that as a limit. If you compare also, we have to consider what the alternatives often are. Similarly, like an hysteroscopy and receptoscopy, myomectomy by hysteroscopy has a longer duration in respect of radiofrequency ablation, even in big fibroids. So it, as you can see, it almost never exceeds 12 minutes, for instance. A very important and very sensitive, of course, issue is the pregnancy, the radiofrequency performance and pregnancy and data in regards to this. And we do need to have more, of course. This is what we are waiting for also to provide, to insert the procedure as guidelines. We need to have more consolidated data. But this is a performed article last year, 2022, yes, in Journal of Minimal Invasive Surgery, an updated review of the literature, where we can, however, report 50 pregnancies among 923 patients, which is, however, a good number, I'd say. And there were no cases of uterine rupture and no reported uterine window or invasive placentation and no fetal complications in this group. And the spontaneous abortion rate was comparable with the general obstetric population, which is important. It's very important when we have to also, yes, talk about our healthcare providers or politicians or a hospital. Yes, when we need to introduce this technique, it's important to have solid data in regards to the obstetric outcome. And most of the publications did not comment or the indication for cesarean delivery among the reported pregnancy, but in 4 patients were recommended cesarean section, but we really don't know if that was due to the radiofrequency or not. And 3 patients also had previous cesarean section, why, of course, they were advised to do another C-section. So what we can say in strengths to the procedure, I would really, I would put the procedure length as one of a very strength in performance, in also introducing this activity in your setting, because besides being a day surgery procedure, you don't have to stay overnight. It's also very quick. So depending about how your organization is, but it's easy to do 6 or 8 procedures in one day surgery setting. Regards to the post-operative pain, we advise our patients to paracetamol or ANS or NSAID, ibuprofen at home. They go home with a scheme, a regimen that they can take. But usually when we call them up after 1 month to see how things have been going, and usually they have not been taking what we have prescribed. So it's a very good sign, I think. Less than the hysteroscopic procedures that have been doing myomectomies. Less pain and less side effects the first day. So they go back to work quickly, and we don't have complications the coming days. It has been reported in literature that you can have pain, a little bit of fever, but actually in our experience, we have not seen so much of that, which is good. So let's summarize a bit, which leaves us also more time for your questions. I see that some of you have been having questions as well. Summarizing a bit what we've been saying so far is that we have a significant decrease in myoma, around 70, but as I said, the other day we called in, it was 3 months, yes, isthmic myoma that has been trying to be treated by hysteroscopy, not resolving because it was difficult with the angle. It was about a little bit more than 3 centimeters. We did that in January, and we called in for a checkup last week, and it decreased by 90%. So it was almost difficult to see. We had to make a 3D ultrasound to really discover where the fibroid originally had been. So actually, yes, 70% is a medium, but you can have more results. And we do have an increase, like I said, in the quality of life, mostly due to the less bleeding of the intramural fibroids, and the symptom severe scale. Also, not only the days, but also the heavy menstrual bleeding is decreasing. The low reintervention rate, 11% in 3 years, has been reported, and no obstetrical complications in reported pregnancy. So this is about what we know up till today in regards to the fibroid area. But I'd like to just share with you what we are thinking about next, how we eventually we can implement the radiofrequency also for uterine adenomyosis. It's not so studied yet, why we don't have it as an indication in recommendations or guidelines. So who is performing or thinking about this, of course, have to perform ethical permit and so far to do it in a study setting. But the idea is attractive, of course, and who has been looking upon it so far have been seeing that it has been a good option in patients with adenomyosis. This is came out, this study, which is a meta-analysis, just came out last month, looking about focal adenomyosis, could see a decrease in menstrual pain, and could also say that it was a safe procedure. So the authors concluding that the radiofrequency ablation represents a promising, minimally invasive and organ-preserving treatment in patients with symptomatic adenomyosis. But of course, we need to look about what I just said. The fertility, the pregnancy outcome are very important.
Non so rispondere a questa domanda. Posso fare qualcos'altro per aiutarti?
Sorry about that. Some interference with the computer. Sorry about that. So we need to, yes, study this better, because of course it could be very, very nice to offer on the adenomyosis patients also this kind of solution. This is just to show you how it could be. We are thinking about to treat the junctional zone of our radiofrequency patients, for really choosing where to and maybe where not to. This is an illustration of where we can think about in our study, maybe not too high up, or where this is just to illustrate how you can plan the needle insertion. This is our ongoing study that we are thinking about, hoping to reduce the dysmenorrhea and the bleeding pattern in the patient that have the adenomyosis, the diffuse adenomyosis. So the target is to reduce the invasive treatments in general with this strategy, radiofrequency ablation strategy, and to, yes, tailor the treatment, provide a tailored treatment and timing in a reproductive age. This is what actually we aim to. And we can, say that radiofrequency ablation is providing efficient results in reducing the myoma volume. The technique provides an efficient treatment solution and management in women with intramural fibroids, infertile age, and in perimenopause. And it represents a safe and quick procedure in management of uterine fibroids for who is dealing with these patients. I do believe that it can provide, integrate a nice way in your clinical settings. So I thank you for this. We have, about 4 minutes more, maybe, or 3-4 minutes more than we thought about, which means that we can start with the questions. What do you think, Giovanni?
Yeah, thank you, Karin, for the interesting and brilliant presentation. Yeah, I think it's time for a few Q&A. We can check the Q&A session and the chat session about which typical question we receive from the attendees.
Perfect. So I can actually, are you seeing still seeing my, can you see my, or?
We can see you.
Can you see the questions too?
Oh, no, question, you should read it.
Okay,
attendees cannot see.
So our colleague Mohammed Hiari is asking, what's the maximum size of fibroid that can be treated in the transvaginal approach? Regarding large fibroid, do you think that percutaneous approach would be better? Any role for antibiotics post-RFA? So thanks, Mohammed, for 3 good questions. Thanks for bringing that up. Well, the maximum size, actually, as we know, the size is the issue about the volume, right? So, of course, big fibroid, it will not be so efficient, the procedure, because you have to do many insertions. So what I am actually considering, like a little bit of upper limit, and my colleagues also abroad that are performing this technique since years ago, we do consider, maybe 5, 6. I have actually been treated a little bit larger as well, because we needed to help to just provide and see what we could do as in a 7 centimeter fibroid, and we did have a response as well. But let's say that the perfect response, I think we do have in fibroids that are 4, maximum 5 size. Then you see this nice reduction in volume in 3-6 months. But there's no actually written or guidelines in regards to this. But what we do as common practice is those kind of size limits. If you do have a large fibroid and we can do it percutaneously, of course, well, it depends a little bit about your habits. If you are used to work with a trans-abdominal ultrasound, of course, you have to be a little bit more aware about the intestinal problems in that. But we do microwaves, and I know a lot of people do with the percutaneous approach, and also our colleagues, our radiologists, they are familiar with the trans-abdominal approach. I actually prefer the transvaginal approach, because if it's a very big fibroid, I do believe that the technique might have this kind of limit, as I told you. And if it's a subseral fibroid, then we do it by another technique, the laparoscopic technique. So if it's really coming out very close to the abdominal cavity, in that way, maybe another approach is actually better for the patient. And in regards to antibiotics, we do give them during the procedure as a default. We give them 2 grams of cefotaxime as an intraoperative procedure prophylaxis, which I think is good, because you do transfer the vagina. Even if you previously to the procedure you do disinfect, but we know the vagina is not sterile, and you have to do at least 3-4 insertions. So I think it's good to provide prophylaxis during the procedure. Then I have another question in regards to Isabella Piotrowska. Thank you, Isabella, for participating. How do we know it's not a sarcoma? And this is it's a very, very important issue, and thanks for bringing it up. I didn't dedicate a section for it in the presentation, but I will be happy to do it now, because I think it's very important for all of us to be sure about what we are thinking about treating. So pre-treatment, pre-surgical ultrasound, very, very adequate ultrasound is of utmost importance. We do today, unfortunately, maybe we did not 10 years ago, but we do have a competence that we didn't have in ultrasound. We didn't have our instrumentation that we do have today. So we are quite able today to see if we do have a typical fibroid or not. This doesn't mean that we say that we can diagnose a sarcoma. As you know, we don't know. That's our nightmare for all of us. But we can see if the fibroid is typical. And these are the fibroids that we need to treat. If you do have any kind of doubts, if you do feel like you need to make an MRI to be sure, or make LADH screening, if you age symptoms, if you do have any kind of suspicious, don't risk to do an ablative treatment. Then it's better to be sure and take histology, not biopsy histology, because we cannot be completely sure, of course, if we do have a 5 or 6 centimeter mesenchymal formation, and even if we do 5 biopsies, how can we know that there's no sarcoma? So the message is patient selection and ultrasound competence. It's actually enough to rule out this issue. We should not send to this kind of treatment a patient with a typical suspect of a typical fibroids or not typical ones. Thank you, Isabella, for bringing this up. Let's see if we have something in the chat. Yes, some. Do you have experience to retreat the same patient? Yes, actually, right in these days, but I will tell you why. This is a particular case, actually, because it's a woman that we treated last year. She's originally from Senegal, which we know that they do have a very particularly predisposer for this problem. She is 35 years of age. She has multiple fibroids. She doesn't want a pregnancy this year. She tried for a pregnancy the end of last year because she's meeting her husband once a year, which is a particular situation. But we treated her last year. She responded very well to her fibroids that were close to the cavity, the G3 fibroids. We treated 3 or 4, and she doesn't have. And those fibroids, like I said, were, shrinked about 70-80%. She came in for a checkup now after 1 year with new fibroids, as she has this kind of genetical predisposal. So she came in a couple of months ago for the checkup, and we found new ones, about 3.5-4 centimeters. And she's telling us, can I do this again? I will meet my husband again at Christmas. And of course we said, yes, why not? Because these fibroids will otherwise grow, and she might not have have luck, of course, we have to counsel her in regards to the general possibilities to get pregnant if you just try once, 1 month a year. That's another issue. But in regards to her fibroids, because she can really wait to have them shrink it again. And then we hope that she can manage to stay more with her husband by 2-3 months in the beginning of next year. But yes, we can treat the same patient, of course. We don't treat the same fibroids that has not happened yet. Another question is a premenopause patient can be candidate? Yes, of course. We have many questions in women that have been set up for hysterectomies because they might have multiple fibroids, so they might not respond to the levonorgestrel IUS, or might not been able to take hormones or so. And we do, yes, we do. 47, 48 years of age, they can also be treated with good results. Let's see if
no, Karin.
Yeah.
So I think we have finished our time.
Yeah.
So the other question, we will respond to the doctors by email as soon as we can. So I would like to thank you a lot for your effort, for your presentation, and for your time and availability. And I thanks all the participants to join us for this webinar. And we will see you next time for the next webinar. Thanks, everybody.
Thank you. Thank you, everyone, and have a good night.
Bye-bye.
Bye-bye.